Welcome to H&HN Daily. I'm Susanna Hopsollerin, Senior Editor for Hospitals and Health Networks magazine. Connecting the continuum of healthcare is a challenge. New care systems require an IT infrastructure to identify areas for improving the quality of care and reducing the costs. Today, I'm joined by Linda Reed, CIO and Vice President of Behavioral and Integrative Medicine at Atlantic Health, based in Morristown, New Jersey, to discuss clinical integration and emerging care systems. Welcome, Linda.
Thank you, Susanna. It's a pleasure to be here.
As we're breaking down the silos in hospitals and we've learned to exchange data within the organization, now we're going the next step to breaking down silos among providers and sharing data across settings. What are the challenges we face?
There's just so many challenges. There is the ability to say who is the legal representative of that patient, who owns the data, who takes action on data. There's just so much to see now, and there's just so many questions as to who the liability belongs to, as well as the benefit. Do you order another test if you've seen that a test has already been ordered? Do you really need it? Do you see a result that's there that maybe you didn't order, and do you take an action on it? So there's just so many things that are going to just open up with the fact that data is being exchanged that we have never thought about before. And I think everyone's very, very concerned about what the liability constraints are going to be once those doors really do open up.
Does anybody own the patient anymore or that patient data?
I think it's interesting, because we've asked for many, many years who own the patient. And I think that goes back to who's coordinating the care. And in many areas, no one coordinated the care. I think we're starting to get to the point where we have to be better coordinators of care, and someone's got to take responsibility. That's one of the questions we get from our physicians that are in our health information exchange all the time. If I see a test that I didn't particularly order and there's been no activity, is it my responsibility to act? And I think the question back is it your responsibility not to act? So again, I think there's just so many questions that we haven't looked at. I think we're starting to get to the point where the patient is going to be owned by the patient. As we start looking at meaningful use, the fact that the patient portals are required for stage 2, patients are going to be seeing their own data more and more. So I think, again, yes, the patient is going to be responsible for their own data, and they're going to also have to be working more closely with many more physicians.
As we're seeing patients across settings, do we have a way of managing accountability for those patient handoffs?
As we see patients across the different settings of care, I think we are starting to see that there is some accountability for handoffs. As we start looking at different models of care providing accountable care, I think what we've seen in our accountable care organization is that the cost for post-acute is where really the opportunity is to start cutting some costs. So we'll start looking at data that comes from those other parts of the continuum and say, is that an opportunity to cut costs, to reduce costs, to increase quality? So I think the more information we get from across the continuum, it's going to help us drive down the cost of care.
What are the clinical analytics that we need in the accountable care organization?
What we've noticed in our accountable care organization, the first piece of data is where are our patients going? In the Medicare program, the MSSP program, patients are not required to just go to the doctors that are in your ACO. They can continue to go anywhere. What we've seen is that they do. They go a lot of places. And I think some of our physicians have been surprised when they've gotten data from our health information exchange that shows the myriad of places that these patients have been. So I think first of all is, who are your patients? Making sure that you've got the right information as who they are, and then where are they going? Only by knowing where they're going, what kind of treatment they've gotten, can you then have some effect on the care you're providing to them right now.
Are we building an infrastructure that will help us with population health, actually having population health dashboards that we can look across settings and report to each of the providers as well as to the community?
In some ways we are, in some ways we're not. Depending on how health information exchanges were built, some of them are more federated, and they don't aggregate data. And if you don't have a way to take a look at data across a population, you may not have the ability to do that. I think more and more organizations are starting to see the value of the secondary uses of data that come out of health information exchange. And you're starting to see more and more people are saying, oh, this is very interesting information. You couple that with information that comes out of state registries, whether it's syndromic surveillance or immunizations, and you start putting that together with the data that you're aggregating in an exchange, and I think you're going to see a very interesting picture. And I think that's when we're going to start being able to put together population health data.
Thank you for joining us today.
My pleasure. Thank you so much.